Well, it's great to see so many of you still here. I don't know about you, but I'm confused. I mean, I just, the more you learn, the more you realize that it's so nuanced that decision-making becomes very difficult. And I think one of the things that I think Guillermo brought out and others have during the day is a key concept of getting the patients involved in the decision-making, which is not something that we used to do even 10 years ago. There was a very paternalistic approach, and now you have to take the time to educate patients and families, and it does take time. It's a very time-intensive process, and you need to get them involved. And this is something that applies to this group of patients as well that I'm going to talk to you about. So, what I'm going to do is I've got 3 cases over here, and I've got a few slides that will talk about really one trial, because there's only one randomized controlled trial, the STICH trial, and a follow-up study of it. We'll present 2 cases, give you a few slides on the STICH trial, and then present the 3rd case and finish up there. It shouldn't take more than 15 minutes, which is what I've been allocated. So we'll start it off with a case. Our first case, JJ, is 46 years old. Each of the cases, by the way, falls into a different age group. This guy's in his 40s, another patient is in his late 50s, and the other in the late 60s. And that's important because the STICH trial, in fact, divided patients into quartiles, and these represent 3 of the 4 quartiles that the STICH trial looked at. Subgroup analysis. So JJ is 46 years old. He's got diabetes, hypertension, hyperlipidemia. For 6 months, he's been having difficulty breathing. He's had a cough, and his ankles are getting big. He works in a warehouse, and finally couldn't take it, went to see his GP. He had a chest x-ray, which I won't show you, but he had a big heart. Sent him to see a cardiologist. He had an echo, and his ejection fraction was less than 20%. He had a cath. Now, not everybody here is a physician and not everybody here is a cardiologist, it's supposed to loop. But in any case, this is his LAD, and he's got a very tight proximal LAD lesion. And he's got a significant lesion of his circumflex as well. The right coronary artery is occluded. So he's got severe triple vessel disease, and his left ventricular function, as you'll see from this ventriculogram, is very poor. I told you the echo showed that he had an ejection fraction of 20%. He had a cardiac MRI. You had a talk earlier today from Dipan Shah on cardiac MRI, and he spoke about many aspects of it, and one of the things that he talked to you about is the value that it brings in assessing viability. Other 2 modalities are nuclear and dobutamine echocardiography. This gentleman had a cardiac MRI which showed extensive viability in the anterior and lateral walls and very little viability in the inferior wall. So we had a discussion with the heart team. All 3 patients that I'm presenting to you today had the heart failure team involved at various time points over the last 2 years. And we had a discussion, and we agreed that this looked like a pretty straightforward case, that he needed to have an intervention, meaning he had targets. He had coronary arteries that you could revascularize. He had a bad ventricle, and he had evidence indicating that there was viability, which we all place a high value on. And that I'll show you why that is something that is still unresolved. He underwent coronary bypass surgery, off pump. We put a balloon pump at the start of the procedure, placed a left internal mammary artery onto the LAD. He's a young person. Most of the time, most surgeons over here, and somebody as young as this, will use both mammary arteries, and that's indeed what we did here. Transit time flow meter measurements, and this, I'll show you a graph of that, showed excellent flows in all the graphs, indicating good function of the graft at the time of surgery. And immediately there was marked improvement in all the walls on echo, including the inferior wall. So this is what transit time flow measurement looks like. It's just a little probe you put around the graft. It uses ultrasound. It's not Doppler, it's a transit time principle, which is a little different. I can't explain the physics, so don't even ask me. And basically you get three numbers. This is the mean flow in the top left-hand corner. This is the pulsatility index, which is a calculated value. The lower, the better. Less than 5 is good, and this was very low. And as in all coronary coronary flow, you would like the predominance of flow to be in diastole, and the diastolic filling here was 68%. This is not actually his flow, but it's a representative diagram that I'm putting up to show you what it looks like. He did great. He was discharged in post-op day 8. His pre-discharge echo, already, ejection fraction was close to 40%, no life vest. 3 months later, he's back in the warehouse, and 3 years later, he's doing great. Next guy, SP, 68-year-old gentleman, farm worker in McAllen, Texas, presented with 6 months of shortness of breath and ankle swelling. Echo, 20%. Cath, 100% LAD, 100% right, and a tight left main compromising his only open vessel, which was a large OM. Here is that tight left main that you can see. Perhaps I should use this thing here. I don't know why the videos aren't looping. I went to all the trouble to, maybe it is. Just a little pause. Yeah. So you can appreciate up here that there is this left main stenosis. I'll use the cursor, it might be easier. Right there, his LED, which is supposed to be there, is occluded, and this large vessel is being compromised by this lesion here. The right coronary artery is occluded, as you can see. And his left ventriculogram is poor, shows poor function. Now, a slight wrinkle over here. CT angiogram here showed that he had a 5-centimeter infrarenal abdominal aortic aneurysm with an irregular mural thrombus over here. Echo, EF of 20%, and his cardiac MRI showed a viable lateral wall, some viability anteriorly, and all scar inferiorly. So we talked about it, the heart failure team, they're all nodding vigorously, and we all said, yes, I think we should operate on him. So we did. Now, we wanted to put a balloon in him. Because of his infrarenal AAA, we placed an axillary balloon pump from the left axillary position, something that our folks have had a lot of experience on, and I believe Jerry has published on. And in fact, he came to the operating room to give us some little technical pointers on how to do it. We did 4 bypasses here, 1 Lima to the LAD and 3 bypasses to the diagonal OM and OM2. Graft flows, again, were excellent, booming graft flows. This is how you put a left axillary balloon pump in. You're in the operating room. Ultrasound guidance to using a micropuncture to access the left axillary artery. You do need a C-arm to make sure that your wire goes down the descending thoracic aorta, as it has a tendency to go into the ascending and can go into one of the arches. This is something that you need to pay attention to. Most times we use a balloon here, which is the 50 cc sensation plus balloon. You need to specifically use the 7.5 French 40 cc balloon. It's shorter and works better for this. So that's a little point that Jerry pointed out to us. And this is what it looks like after it's inserted. The head of the patient is to the right, of course. He had an uneventful postoperative course. His post-op echo showed 20 to 24%. He was discharged on day 7 with a life vest because he still had an echo less than 30%. And he returned 6 months later for his EVAR. His echo at that time showed that his EF had now improved to greater than 35%. So the first patient showed improvement prior to discharge. The second patient took several months to demonstrate improvement, illustrating that there can be variation. Hibernating myocardium will frequently take months to come back. And he did not need an ICD. He is doing well, and he is back at work on the farm down in the valley. Now, the early trials of coronary bypass surgery versus medical therapy, the 3 great trials that were published in the, they were done in the 70s and published in the 80s, were the VA study, the European coronary surgery study, and the coronary artery surgery study. And in 2 of these, they were able to demonstrate in a small subgroup analysis that if you had a bad LV, in addition to triple vessel disease, you were more likely to benefit from having CABG. There were many limitations to these trials, and it's worth pointing out a few. The benefits of CABG were underestimated for severe disease because most patients who were enrolled were very low risk. CABG was not so sophisticated, methods of myocardial protection, et cetera. The results were analyzed on an intention to treat basis, and more than 40% of patients who were assigned to medical crossed over to CABG. Only 10% received an IMA back then because it wasn't routinely done, and there was no survival benefit for CABG in patients with normal ventricles or single or double vessel disease. Next. Now, fast forward since then, since the 70s, there has not been, until recently, not a single randomized controlled trial that looked at the potential benefit that CABG might have for patients with impaired left ventricular function. Lots of trials comparing CABG to PCI, CABG to best medical therapy, et cetera, but nothing that specifically identified this very difficult problem that we are actually confronting in greater numbers today as we have patients with heart failure, people are living longer, and it really is an epidemic. I mean, I'm all cardiac surgeons. Scott will testify to this. We are seeing so many patients like this. So the international randomized control trial is the only one of its kind, remains that way, and it's not likely to be repeated because it was a very difficult trial to perform, extremely expensive, and they enrolled between 2002 and 2007. There were 99 centers, 1,212 patients with an ejection fraction of less than 35%. Half of these, more or less, were assigned to guideline-directed medical therapy. Very important. You've heard folks speak about that earlier today. It's very different. You really have to pay close attention to compliance, to what they're doing. It's time-consuming, but it's important. And half to medical therapy, guideline-directed medical therapy with CABG. The follow-up was astonishing, 98%. And this is 99 centers in, I don't know how many countries, but it was all over the world, basically. The 5-year results were reported in 2011 in the New England Journal, and it was disappointing because there was no significant difference between medical therapy and medical therapy plus CABG with respect to the primary endpoint, which was death from all cause. Now, they looked at subgroups which were not really powered to give any kind of rational answer, but they did it anyway because it's too tempting not to do. And they found that those patients who were assigned to CABG had lower rates of death from cardiovascular causes and death from any cause or hospitalization for cardiovascular causes. So they thought they saw enough of a glimmer of hope there in those 5-year studies that even though the 5-year follow-up did not show the significant difference that they hoped for, there was a trend. And they sort of thought there might be something in, and the investigators agreed to continue following up those patients to give a 10-year follow-up. This was reported last year. And guess what? It did show a significant difference at 10 years between medical and medical plus CABG. It showed that in death from any cause, which was the primary outcome, death from any cause, CABG was superior to medical therapy at 10 years. This was the 5-year point where it was not significant. At this point, the significance level had a p-value of 0.02. And you see that the rough, these are the event rates over here. Now, not surprisingly, they showed that this advantage was more marked in younger patients. These are the 4 quartiles that they had broken patients up into. Green is the youngest group. Blue is 54 to 60. I don't know what color that is. Is that magenta, purple, violet? I don't know. Whatever that color is, 60 to 67, and orange was greater than 67. So old people didn't do as well, but as Brian pointed out earlier, old people die from other reasons too. So there's that to consider, and that's probably the reason why that was the case. Death from any cause or cardiovascular hospitalization also showed that there was a significant difference. and death from cardiovascular causes. So we think that, okay, we've got an answer now, and we think we can do something to help our patients. But in this trial, of the patients that were recruited, half of them, roughly, had a viability assessment. None of them had CMR, MRI. They either had SPECT or dobutamine echo, and half of those were assigned to medical therapy and the other half to medical with CABG. And they found that numerically, it appeared as if those with viable myocardium were more likely to survive. They had a lower death rate. But in fact, when you adjusted for baseline variables, there was no difference. In other words, assessment of myocardial viability does not identify patients who will have the greatest survival benefit from adding CABG to aggressive medical therapy. Yet we use it all the time because it's a number. You can get it, you can hang your hat on it, and you can pretend that it's something that you can make a decision with. So it leaves open the question of how to identify the individual patient who will benefit from CABG. So the limitations to STICH were there are only 12% of women. These are limitations to the external validity of STICH, meaning applying it to the general population. Only 12% of women in this. The mean age was 60. Most of our patients that we operate now are way older than that. And only 16% of patients in this trial were greater than 70. Recruitment was very slow, 2.5 patients per year per center. In fact, they had to reduce the numbers of patients that they were going to analyze and increase the follow-up because it was so difficult to get patients recruited in the trial. And likely these centers were very experienced because they had to demonstrate extremely good or low mortality rates in patients in high-risk patients with CABG, not a reflection of the average place. The other very significant thing was that ICD use was low. But this was equally so in both groups. And the reason was the patients were recruited from 02 to 07, and the really good evidence showing that ICDs helped patients in low EF, with low EF, really came out in 2005. So that's something to note, but it affected both groups equally. And of course, subgroup analyses are all underpowered. So with that information in mind, our last case over here, KF, 57 years old. Safety inspector at a plant, comes in 4 days, I'm feeling lousy, and he's got a cough. He's not eating or drinking much, he's lying in bed, he fainted in the bathtub. No chest pain, but his wife called the ambulance, they took him to the hospital, his troponin was 5, he had a CT chest negative for PE. This is his echo, and you can see quite readily that in this 4-chamber view, this view of the left ventricle, he's got extremely poor left ventricular function. This is another shot demonstrating the same thing. And his cath showed that he had an occluded LAD with severe disease affecting the vessels of the circumflex system, but what looked like not great, but bypassable targets over there, 3 targets. 57 years old, remember. Doable. Lousy right. LAD filling retrograde, not great targets, but he's 57, and it's doable. It's not ideal, but it's doable. And the left ventricle, of course, is just bad news all the way. Okay? So, what did we do? We did a cardiac MRI on him. Well, this is another thing. When I don't know what to do, which happens a lot, I do 2 things. I order tests, and I ask other people, what would you do? So we got a cardiac MRI, severely enlarged left ventricle, ejection fraction 21%, normal wall thickness, okay? LAD territory transmural infarct, 33% scar, so burned out, predominantly non-viable, circumflex and right coronary arteries, extensive viability, right ventricle is normal, moderate MR, moderate TR. So I went up to the lab and I looked at the echo with Miguel Quiñones, who's not here. But I was going over this with Miguel, and he said, yeah, the wall thickness looks okay, except at the apex. And interestingly, his LV filling pressures were normal. Now, this could be a reflection of the fact that his LV is not that bad, or it could be a reflection of the fact that he'd been in hospital for several days prior to this, and Jerry had been diuresing the wazoo out of him so that his volume status was way down and his filling pressures were down. He was just being well managed. You know, the acute heart failure management was good. So then Miguel said to me, what about his ECG? So we pulled out his ECG and I put it here for you, and look at that. He's got good R waves. And so we said, this is sort of old-fashioned decision-making, but I think with good R waves and, you know, all this stuff, we're not going to believe all this other stuff. So he said, operate on him. So I said, oh, okay, he's 57, but yeah, okay. So May last year, did an off-pump bypass, Lemur the LAD, vein graft to those vessels. Good transit time flows in the graft. Surprisingly, in spite of those targets, I was very happy. Post-op echo, ejection fraction 20%. Good recovery, discharged on post-op day 12. Couldn't get a life vest, didn't have insurance. Went home without a life vest. Came back in September. By now, he had insurance. Ejection fraction was still 20%. Class 2, 3 CHF, still not back at work. Got an ICD. Miguel Valderrabano put an ICD in him. Came back in December, got an LV stem cell injection as part of the TIVA DREAM trial. Came back in January, Barry Trachtenberg saw him I guess, a month ago, 3 weeks ago. And May to January, now what is it, like 7, 8 months after his operation, he is still shortness of breath. He still gets short of breath with minimal exertion. He is completely homebound. He hasn't left the house. His EF is still 20%. He feels awful. His life hasn't changed. So what to do? How do we pick the right patient? And the recommendations over here, I've already showed you that for CABG in patients with LV dysfunction, if it's less than 35%, it's a 2B with a level of evidence B. And in all 3 patients, we used the heart team approach, but in spite of that, I think in this last patient, you know, myocardial revascularization didn't help him. I don't think that even if we were to do it all over again, that we would do anything differently with him. But it teaches us that there is a proportion of patients who won't respond to it even though you think they will. Decision-making has to be individualized. The patient needs to be involved in making the choice. And ischemic heart disease comes in many shades of gray. I won't say how many. Ischemic. So for some years now, for about 4 or 5 years, I think I started this about 5 years ago, we've had an ischemic conference twice a month where we discuss cases every other Friday. Some of the people in this room come to it on a regular basis. And those that do know that even the most straightforward cases in coronary disease can provoke all these, you know, arguments amongst people. You've got the interventionalists, and you've got, you know, the medical therapists and the surgeons, and if that happens in straightforward cases, these cases are really the most difficult ones to make decisions in. We just started an ischemic clinic to look at high-risk patients. In fact, the first one is on February 17th. Is on February 17th this year, and I would ask you to send us your sick. So the future for coronary artery disease is that it needs to be approached with a multidisciplinary approach. It's like cancer. It's about disease management. It's about patients, not procedures. There's a convergence of all the possible therapies that we have, and the syntax score, which I didn't talk about, is a major contribution. The heart team approach is essential, I think, for optimum care, and if you're not doing it where you work, you need to start. Thanks.